So we're going to go to Mark Murray next, but before we do that, I was going to, in my first round of comments, show a couple of images as to how the Planning Committee has conceptualized the scheduling system, but I made a decision to defer that to now because I think it segues nicely with what Mark will be talking about. And just two images. We have thought about the scheduling system really as the bridge between the patients and the providers in all of their different forms. And this is perhaps the most simple form of that, and that the scheduling system would not only facilitate and improve access to care, but it also would be a tool to promote continuity of care and also coordination of care. If I can have the next ones. Well, before you go there, so in the simple sense, basically you have a patient on as you're facing it on your left side, and then a bunch of providers on the right side. And from the patient's perspective, that's really all they care about. They need something done, and so they need to access the system through the scheduling system. And if I have the next image, it obviously gets much more complicated in reality, in that these patients come from urban and rural settings, from nursing homes, from a variety of other settings, including remotely and having virtual access. So in all of those guises, as the patient is seeking care, then of course in the current system, or certainly as VA goes forward, there's the VA providers, both primary care and specialty care, and in our mindset of how we promote continuity and coordination of care, obviously primary care and specialty care have to be intimately linked and connected. But as Dr. Lieberman noted in his comments, one of the things that's going to be increasingly a part of VA care going forward is working with the community providers. So then we have all these entities. These are the red crosses on the outside of hospitals and clinics and private practitioners and others who are then going to interface with the VA, and somehow the system has to facilitate those connections in addition to the connections within the VA and all the different types of specialty care that will be interfacing with primary care. So it's obviously much more complicated than the patient may think about it, but the system should make it as easy as that first image for the patient to think about. I just need to access the system, and then the system will take care of all of those complexities as to where I need to be seen and with whom and how the records get communicated with each other, and all of that should be largely invisible to the patient who is using the system. So with that as a preface, because in many ways this concept antedates this forum, and in 2015, the VA asked the National Academy to hold a session not unlike this on how to transform the healthcare scheduling and access, which resulted in a report, which I understand actually has been used, hopefully it has been, and had some good ideas in it. And we thought it would be useful to provide a quick overview of what that report said 3 or 4 years ago when it was done. And if the technology gods smile upon us, Mark, are you here with us?
Yes, I am. Can you hear me?
Great. You're coming in good.